Okay, so what we're talking about now is the central line, and this is to augment your central line chapter. And what we're going to do here is describe everything you need to know about the central line itself, and then it'll make more sense when you start studying all the information in your chapter. So we are in the non-tunneled chapter. There are two types of central lines, tunneled and non-tunneled. We are talking about the non-tunneled. Now, non-tunneled would be temporary, short-term. They'll be in the hospital under nurse's care. So let's take this apart step by step. When we look at this, you have a choice, your physician has a choice of how many lumens he wants to put into the patient. And I will tell you, the more lumens you have, the sicker your patient is. So if we had a triple lumen like this, they're going to be in ICU. They have a single lumen, and it would look something like this. That means they're only going to have one type of therapy, such as chemotherapy, antibiotics, narcotics. But when they have more than one lumen, and this one again is 3, that means they have to have several different types of therapy performed at the same time. So it's going to be sicker patient, more lumens. So let's go from the top to the bottom. So here we have a triple lumen. If you look at the end of each of these exit ports, you'll notice this one's different than these two. And I'm going to take this green cap off. We'll talk about that later. You'll notice that these are different. Even with these two are different than this one. Now, the reason we did that is to show you, even though these caps do exactly the same thing, and they're built pretty much the same way, each manufacturer gives it a different look. It could be blue like this one, it could be transparent with blue, it could be white. So even though these function the same way, they all look different depending on the manufacturer. So what I did was I bought all these different caps from different manufacturers so that you know that they all look different. But you would know that if we are working with one company, all of these end caps are going to be the same. And that would be a good example right here. Okay. Now these green caps, we'll start from the very end. These green caps were invented because our infection rate on central lines are up 60%. That's 60%. The reason being for that is a lot of nurses and healthcare professionals are not cleaning these ports like they should be when they access the central line. So a company had the bright idea that they would make these caps, and it's kind of hard to see, but we will be passing these out in class. You'll notice there's a little sponge inside the cap, and it is saturated with chlorhexidine and alcohol. Now 2% chlorhexidine kills just about everything, and it's nice and wet. And these have foil on the top. You peel it back, it's sterile, don't touch it, and you would place it on the end of your safety caps. So this was invented to keep the infection rate down. If your hospital does not provide these, and there's 2 companies that make this. One company makes them green, the other company makes them orange, but they do the same thing. If your hospital does not provide these caps, the ends of your exit ports will look like this. The reason they're threaded, it looks like they're kind of naked, but the reason they're threaded is so you can put syringes on the end, and they screw in place. You can put tubing from your catheter, actually from your IV tubing. They're all threaded, but that's why it's threaded. They don't have to have anything on the end unless your hospital provides these safety caps. All right, the whole purpose of these caps is to protect your patient from microbes getting in and blood getting out. If these caps were not on and these slide clamps were not clamped, your patient could lose quite a bit of blood because this is a direct conduit to the vein. So we have safety devices, one being the slide clamp, always has to be clamped if it's not in use or you're not accessing, and we always have this cap on. It's an access cap, always in place. And again, they do look different depending on the manufacturer. So the first thing I'm going to do when I come up to my patient who has a central line, I make sure all of these slide clamps are clamped. So it's either going to be a slide clamp like this, and you just slide it, and it is clamped, or it's going to be a snap clamp, the white ones that you snap together and clamp it that way. So either way, it's going to be one or the other. Next thing I'm going to do is make sure my caps are all in place and tight. Now if you were to look at these caps, the way that they are made, one end has to be female, the other end has to be a male, and that's the only way that we connect different devices to each other in medicine. The male has a little thingy here on the end, the protrusion, and it always fits into the female. Now the female is always going to be a hole. So male to female, and you twist it and it locks into place. The female end on this, do you notice it has a silicone port here? It's a cover. This is the valve. It's a safety valve. It stays locked when it is not being accessed. The only way to open this valve, the silicone valve, is to introduce a male end into it. And syringes have male ends. So if it was time to flush this catheter, I would insert my male, screw it in place. Now that opens the valve, and this would be attached already. That opens the valve, and I would be able to flush my system. I would not be able to flush at this point because I have the slide clamp clamped. So I would have to open that up, and then I could access my port and my catheter. Okay, so that's why these caps are in place. It's safety. Now a few things you might need to know about these caps. They have to be replaced every 7 days, no matter what. Every 7 days. They could also be replaced PRN. So if you feel that it's got some stuff in it, like maybe you just did a blood draw, or you feel it hasn't been replaced, or it hasn't been charted that it's been replaced in 7 days, you go right ahead and replace it. They're kept in a sterile peel pack. But the one thing we always know about anything that's attached to a device that goes in the patient's vein, you have to get all the air out. Now there's a little tiny air bubble in here when they come out of the sterile package. So what you have to do is get your syringe full of saline. This is always a saline flush. Now remember, these are pre-filled, but they always have a bubble in them. And to get that bubble out, you have to pull your syringe plunger back first to get it loosened, because they're kind of stuck. And then you are going to gently push the bubble out. Okay, so once the bubble's out, you are ready to flush. So male to female. And this end will have a cap on it to protect the sterility. And then you're going to push the air out. Good, that's it. And you're going to put it on the end after you've taken the old one off. Screw it in place. While you're there, you might as well flush it. You're just trying to keep it clean. So we are going to go ahead and flush it. Now how do I know I'm in the vein before I flush? I would aspirate. So pull back on your syringe. Now the blood, you do not want it to come all the way back up into the syringe. That would be gross, because you would be flushing with diluted blood. So what you're going to do is you are going to aspirate a little bit till you see a little bit of blood right here, and then you are going to flush 3 to 5 mLs. Because you have your flush syringe on there, you might as well. And I will be showing you a technique on how to flush correctly in just a few minutes. So once you're done replacing that cap, if your hospital provides these green caps, you get a brand new one, put it in place, and you're done. And if you replace one cap, replace all of them. It's a lot easier to chart that you've done all of them as opposed to one at 1 o'clock, the other one at 3 o'clock. It doesn't make any sense. So make sure that you do chart that you've replaced them all. Okay, so those are your caps. Talked about your slide clamps. Make sure they are always clamped. Even if it's not your patient, you walk by a patient and you find that these clamps are unclamped, make sure that you go by and you clamp them. These need to be clamped. It's for safety. Now what you have to understand is these 3 exit ports are attached to 3 catheters side by side underneath this blue sheath. It's like if you took 3 straws and taped them all together side by side. That's what's inside here. 3 separate catheters the entire length. As a matter of fact, the 3 catheters continue as the exit ports. The information on this little triangle tells you what type, how big it is. This is actually a 7 French. It tells you the company, and it tells you the model number. So if you get a transfer from a facility that they don't have any charting on what this is, you can always Google this number, and it will give you all the information you need in the way of maintaining it. You'll notice there's hash marks here. This is used for insertion. We do external measurements on our patient. We'll say, well, there's so many centimeters here, so many here, so many here. We add them up, and when we put this into the patient and thread it into the patient, we can mark off these hash marks. They're centimeter marks. So let's say it would take 14 centimeters for external measurement. We can mark off 10. There's 15. We'd have to be careful at this point. So you will have excess outside of the body. And that's the other thing, is once you see this catheter in, whoever was assisting with the insertion or was the nurse with this patient during insertion, when you chart, some of the information that you chart has to include how much of the catheter is outside of the body. So I would say there's 4 centimeters outside of the body if it was here, and it better be 4 centimeters the next day. If it isn't, that's called migration, if it moves in and out. And that's very important that you don't allow that. The physician, once they get it inserted, will use usually suture to attach this to the patient's skin. Sometimes they can use staples, and sometimes they can use stat-lock dressing, which is snapped onto the device, and it has adhesive that goes to the skin. So, from top to bottom, you really have to know if you're going to be in charge of this, and once you're certified LVNs, this is under your scope of practice. You can access this device when it's in your patient, and what you're going to be doing with this is making sure it stays patent. You have to make sure that platelets do not collect on the opening of your device. Now, do you see these 3 different holes? There's one on the very distal end, there's one about 1 inch proximal, and there's another one about 2 inches. So it's an opening, opening, opening. And they correspond to these exit ports. And you'll notice how they're staggered. The reason they're staggered is because the openings are staggered. So the shortest one has the most distal opening. It's the furthest away, which is why this is the shortest exit port. And by the way, these are all the same length. Originally, they're all the same length, but since their exits are staggered, they're going to be staggered. So the distal port is always the shortest because its opening is the most distal. The medial port is the next longest because it's got the medial opening, it's in the middle. And then your proximal port has the opening that is the most proximal here. So it is the longest because its opening is the most proximal. So that's why they're staggered. And I will tell you one more piece of information. Your distal port always has the largest diameter. So this is a 16 gauge, the other 2 are 18 gauge. And that's why this is the color of blood. If you're going to have any blood procedure, such as withdrawing blood or giving a blood transfusion, you would use this port because there's less damage to the RBCs because it has a larger diameter. Could you use the other ports for blood transfusion? Absolutely. We had a patient that had gunshots not too long ago, and we had 3 units of blood for each port because he needed blood very badly, because he was hypovolemic. So, largest diameter port is your blood port. The other 2, if you're giving blood, the other 2 could be used for blood. And I get a lot of questions, which one do I give TPN in, which one do I give medication in? It really doesn't matter unless you have a policy specific to your facility. They may want just TPN in the blue, medication in the white, blood in the maroon color. It could be opposite at another hospital, so just follow your policy and procedures. But realistically, you could put drugs into any one of these, but if you're going to do any blood procedure, make sure it's through the distal port. The other thing is it will give you information on these exit ports. These have been rubbed off, but it will tell you the name of the exit port, and it'll tell you what the gauge is. It'll be labeled. Okay, so that's A to Z, everything about your central line. And what I'm going to show you next is how to flush it and keep it patent. And I think one thing that helps a lot with visualizing your central lines, because they can be scary, I want you to think of your central line as being the G-tube to your vein. And you will find out in just a second that it correlates very closely when you talk about any tube that goes into the body, whether it's the stomach, the vein. Anytime you have an apparatus that goes into the body, you have to make sure it is free of air, especially when it's in the venous system. And you have to make sure that you know everything there is to know about it so you can troubleshoot it. So if I have this in my patient's body, now this is the subclavian approach. We're saying that it's sutured in place. And it's time to make sure that it is flushed. So that's called what we use, an acronym called SASH protocol, and that stands for saline, access, saline again, and heparin whenever the doctor would like to be given. So the SASH protocol keeps the tips from getting occluded with our platelets. Now when platelets swim by, and I'm making this kind of a visual, when they swim by and see these holes, they would love to plug it up, because that's what platelets do. Unless we push fluid through this at regular intervals, these openings, the platelets will collect and cause a fibrin tail and a plug, and these will be useless. You won't be able to use them once they're clotted off. So we're trying to keep the clot from forming on these openings. The only way to do that is to flush these catheters at regular intervals. Now when you have a G-tube in your patient, like I said, this is the G-tube of the vein, but let's go to a G-tube. Before you feed your patient with their G-tube, what is it you do first? Well, you flush it to make sure it's patent, and then you feed them. And what do you do after you're done feeding them? You flush it again to make sure it's patent and nice and clean. We're doing the same thing with our central lines. If we're going to use it, we call that accessing the line. If we're going to access our central line, we have to clean it first, make sure it's patent, use it. It could be anything, giving blood, drawing blood, hooking it up to an IV. Once we're done using it or accessing it, we are going to flush it again to make sure it's clean and patent after we have used it. So again, you clean it, you use it, you clean it. And every now and then the doctor would like you to give a dose of heparin, but it is not every single time that you sash your catheter. Now when we do this, these are your normal saline. They come pre-loaded, and again there's always a bubble in them. You have to make sure the bubbles are out. And the way I do that is I pull back first on the plunger because it is stuck. They do that so it doesn't move in transport. Okay. And once you pull back, you have to make sure that it's lined up perpendicular to the ceiling, and you very gently get your bubble out. So that's more control. When you pull back first and then get your bubble out, you have a lot more control. So once there's no air in there, and I do have to stress the importance that you cannot have any air in your catheter, because that'll go straight to the heart. And once it's in the heart, your patient could have, well, we'll just say negative consequences. So what I make sure I have is a couple of these, and these are two different companies, but I will tell you saline has the white label. If it's heparin, it could either be yellow, and this is heparin, it's labeled heparin, and another company makes heparin that's blue. So you really have to watch out to make sure you read this first so you're not injecting heparin instead of your saline. So every time you do SASH protocol, you will use 0.9% sodium chloride, anywhere from 3 to 5 mLs. Can you use more? Sure, if your patient is not on fluid restrictions. Pediatric is different, we're talking about adult right now, but you can absolutely use more than 3 to 5 mLs. Always make sure when you are pushing this, if you decide to use the whole syringe, which is fine, always leave 1 ml in your syringe. Never empty the syringe into your patient, their central line, because there might have micro bubbles in there, and that could be very dangerous for them. So what I'm going to do, and since we do have that 60% increase in infection, hopefully you have your little caps, your green or your orange ones, and I always start with the same exit port each time. I usually go short to long, and because we're OCD, as nurses. Long to short, short to long, but do it the same way every time. Less mistakes. I take off the cap. I'm going to throw this away because it's only good for a certain amount of hours, and I want to toss it. So I have a new one ready. I'm going to remove my cap on my syringe, and I'm going to get the air out. I'm at kind of a funny angle here, but I would normally pull back and then make sure that the air is out. And there's no air in there. What am I going to do with this cap? Do I just assume that this was a fresh, clean green cap, the last nurse who used it? Maybe, maybe not. Sometimes when we're short on caps, they'll just put the same cap back on. This could be all dried out for all we know. So we're going to take best practice, and once we remove this, we're going to get an alcohol swab, and we are going to clean this at least 10 to 30 seconds with lots of friction. Let's pretend I have an alcohol swab. Once that's done, without touching either end, because I don't want to contaminate it, I'm going to push, twist, and this is where I have to prove that the tip is in the vein. And to do that, I would open the clamp, aspirate just a little, and I don't want, again, the blood to come up into the syringe, just a little bit here in the tubing. And I'm going to hold my clamp ready so I can close it. So once I aspirate and I see that I'm in the vein, I want to get 3 to 5 mLs in, but I want to do a stop-start. So it's going to be stop-start. See how it's stop-start? And that does a really good job of cleaning the inside of the catheter. Whoosh, whoosh, whoosh. So it does much better that way than just a straight continuous flush. So I have started doing push, 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 push. Near the end, remember I want to keep 1 cc in. I push continuously and clamp at the same time. So I'm pushing and clamping at the very end at the same time. So I'll do that one more time. I've already washed it. I aspirate, and I am open. I aspirate, get my clamp in, ready to clamp, and I'm going to push, 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 push. At the very end, I'm going to continue to push and clamp. That way, you will not have negative pressure on the tip, because every time you stop pushing, it sucks in some platelets. It's just physics. Okay, so I'll have a continuous, I clamp. Once I remove this, put a brand new green cap on, that's sterile, and I would do it to the other ports also. Remember, if you're going to do one port, do them all. And that's basically the breakdown of your central line and how to maintain it.